Thanks, Amy, and thank you to Warm Hearth and to the Virginia Tech Human Resources Department for having the foresight to have sessions like this, helping you and us to deal with a coming and already here problem, and I'll kind of get into that in a minute. But first I want to just say, while I don't have any financial disclosures, I do have a philosophical disclosure to make. And while I think the topic of my talk is aging in place, and while I think it is should be the absolute goal for all of us, for our loved ones and for ourselves to be able to age in place. And as my wife says, I'm not moving from my current house until it's in a pine box. I want that to be the case for her because that's what her wish is. But the reality is, as hard as we try and as hard as we tap into all that's available, and we're going to talk a lot about that this afternoon, sometimes staying home isn't the right answer, and we have to understand when that time is and what the right answers are. So again, the topic is aging in place. That's a fine goal, and we all ought to strive towards that goal, but sometimes the goal needs to be modified at some point. Now, I'm gonna tap into the expertise of two experts on aging. My research into giving this talk really utilized Dr. Seuss, who authored the book "You're Only Old Once." And the tagline for that was a book for absolute children, and I would say the new tagline ought to be "So Embrace It." Because I believe that our aging population has so much to give, and we run the risk, if we're not careful, of ignoring the wisdom that they bring and all that they can give. So as we age, and the older I get, the more I recognize that. Maybe I'm deluding myself into thinking I have wisdom, but the older I get, the more I recognize the wisdom of age. And the second expert is Maxine, who tells us, don't let aging get you down. It's too hard to get back up. U.B. Blake, on his 95th birthday, and U.B. Blake's 95th birthday was in 1982. So on his 95th birthday, he said, if I'd known I was going to live this long, I'd have taken better care of myself. In 1982, 95 was a pretty big milestone. We didn't have many people 35 years ago who lived to be 95. Nowadays, I can tell you that at some of the nursing facilities and assisted livings where I go to, 95 is not that uncommon, and that's the case across the board. It's not just because I happen to go to places that have attracted the oldest of the old, but it's because of the demographic change. And I'm going to spend a little bit of time this afternoon describing for you the demographic change that's occurring, why it's occurring, as a foundation for discussing aging in place. So this is a slide that if you've been to any geriatrician, we're not allowed, geriatricians aren't allowed to give a talk without showing this slide. This kind of justifies our existence. But this is just the slide that demonstrates the population and what the current and projected populations will be. And if you'll notice, this is about where we are right now, right? And go up to 65 and look at the slope of the upward curve beginning right about now. Why is that? Yeah, the baby boomers. We are there. This is the beginning of the baby boomer age a couple of years ago, and it is going to take a steep rise. The 85 and over population is on kind of a curve that we were on for the 65s for a while, and then in 2030, baby boomers are going to be 85, and the curve is going to go up like that. So what does that mean? That means we're going to be older, but what it means is that, and I don't want to get political here, but this is a problem that our elected officials are ignoring. They're kicking the can down the road to the detriment of our children and our grandchildren, because something has to be done here. And I believe a solution to what needs to be done is supporting aging in place. We don't need to build more nursing homes. Are the Warm Hearth people here? We don't even need to build more assisted living facilities, I believe. I believe we need to support aging in place so that we can keep people at home longer, safely keep people at home longer. We can always keep people at home longer. So this is, when I was a geriatric fellow, which is more years than I want to remember, we talked about the pyramidal aging demographic, and it wasn't 1950, by the way. I'm not quite that old, but you can, every 10 years there's a new pyramid or a new demographic table that's created that shows this. And for most of the mid to late 20th century, this is about what it looked like. It was pretty much a pyramid. With the largest segment of the population being children and adolescents and people into their 20s, and then with each succeeding decade, the size of the population decreased ever so slightly. Yes.
I would love to hear, before you go too much further, how did you come to the decision to study in the geriatric field?
So the question is, how did I come to decide on studying geriatrics? And that's a really great question. So I started a geriatric fellowship 15 years ago, and I'm going to answer your question in a second. But one of the questions I ask anyone who's interested in doing a geriatric fellowship is, why? Why do you want to do this? I mean, this is hard work. The answer I get is pretty much the same answer that was my answer, almost always the same answer that I gave, and it's twofold. One is, and every single, I honest to God, without fail, everybody who says this, they have two reasons for wanting to go into geriatrics. One is, there was an old person in their life, a grandparent, a friend, someone who they just kind of sat at the feet of and were in awe of, and that person became the whether it was the grandfather or not. Most of the time it was a grandfather or grandmother, but whether or not it was, became that grandfatherly or grandmotherly figure in their life. That's number one. And the second reason is that even though it's hard work, it is the most fun population to take care of. And I will say that to my dying day. I love taking care of older people. Now it's becoming a little bit less fun, not because of anything other than 20 years ago, the stories they told were stories I hadn't heard before. They were stories of life. They were stories of life that existed before I existed. And I love hearing stories, and I love understanding how people get to be where they are. Now the stories I hear are stories I can relate to. Unfortunately, I said, oh yeah, I lived through that. I remember that. Yeah. So the stories aren't quite as fun and new to me as they used to be, but I still love it. And everyone that I know of that chose the field of geriatrics or gerontology or geriatric nursing or whatever, those are the two reasons they give. So as I mentioned, until about 1980 to 1990, this really was pyramidal. Pretty much every time you looked at this, it was pyramidal. Here is the 2014 picture, and notice the incredible difference. Now, they're not just the shape. Let me show you let me point one other thing out to you about the difference here. This one topped out at 85 plus. So in 1950, they didn't even consider that. So 85 was that magical age where only the supernatural people that have whatever are going to live to. And in 2014, the top is the 100 plus. So if you really compared these two graphs one by one, you would have to incorporate all four of those last four blocks into one, and it would be pretty close to even with the 80 to 84 range, right? So this has implications on our healthcare system, on our economy. This has huge implications on our economy because, these people aren't working, and somewhere up in here, wherever you want to draw the line, people aren't working. So your percentage of the population that are of working age and are contributing into Social Security and contributing into Medicare and contributing into the systems that provide support is diminishing and diminishing with each passing year. So once again, we're not addressing this change in the demographic. So a question was asked, this was just a couple of years ago, a question was asked, after which life events would you consider someone old? And I saw this slide and I incorporated it in here because I find it interesting how if you'd asked me when I was 15 or 20, what I would consider old, it would have been something like this. My grandparents were old, and in fact, my grandparents really weren't that old when I was 10 or 15 years old, or when your hair is gray. But look at the percentages that consider that to be old, and when you retire. Does anyone in here think you're old when you retire? No, of course not. Because I see the age of the people in here. Maybe the guy in the camera, he might think you're old when you retire. But otherwise, retirement is for young people, right? Trouble hearing. God knows if that were what makes us old, my definition of old would be completely wrong. Serious health issues or diagnoses. But what it is the big one is when you're no longer able to live in your home. That's the defining moment for the largest percentage of people on this survey of what makes you old. Driving and independence at home are those two things. Some of you who've heard me speak before know that I consider myself Roanoke's public enemy number one for the old population, because I'm the guy who tells people they can't drive anymore, and they hate me for it. But I've got to be honest, and I've got to protect society as well as the patients that I'm seeing. So the bottom line to this is 80 is the new 60, right? I'm convincing myself of that. A couple things about mortality, and this kind of flows into why we're older. It's because we're obviously dying at an older age. We're living to be older, and this just kind of demonstrates what the expectation is for median age at death, even up until 2100. And you will notice I keep wanting to press the wrong button. So if I flip forward in slides while I'm trying to find the laser pointer, that's just me. One thing to notice, and we saw this with this year's census, by the way, is that we're flattening out that rise. If you paid attention to the statistics or the median age at death for our population, it's really been rising at a pretty steady rate across just about all demographic, all races and both genders. It is now flattening out, and I remember some geriatricians when I was training and early in my career talking about how it was going to continue at this rate. This is the rate when I trained, and it's going to continue at that rate, and the median age at death is going to be in the near 100. I was always a little skeptical of that, and always a little hopeful that wasn't going to be the fact. I know a lot of 100-year-olds, and some of them are wonderful and healthy and doing well, but most of them are suffering in one fashion or another. But be that as it may, we're beginning to flatten out a little bit, and I think that trend is going. I personally think that trend is going to continue. That we're not going to magically find that potion for aging, and stop death in its tracks. Life expectancy is the number of years you can expect to live beyond your current age. So for instance, at about now, life expectancy, so for a 70-year-old, somewhere now, a 70-year-old can expect to live an additional 12 or 13 years. That's what life expectancy means. And notice once again, what I showed you in the last slide, we're flattening out. We have been in a steep rise, and I'll talk in a second about why we've been in this steep rise. I mean, there's a reason why we've been in this steep rise. But there's also a reason why in my opinion anyway, it's going to flatten out. Just another slide about life expectancy that separates out men and women. Women have been gaining more years than men. Women always live longer than men, but they've been gaining more years than men through the course of the last half a century as well. Labor force participation. This is a really interesting slide, those of you who remember back here, so you'll notice that. Let's just focus on this population right now. You'll notice that the labor participation was almost 50% for the 65 to 69 age group. And remember, the life expectancy at that point was, in the 1960s, was only about 70, 72 maybe. But the labor force participation was at about 40% among 65 to 69-year-olds. And then a steep drop. You know why that steep drop? Anybody remember why that steep drop occurred right here? That's where Social Security and Medicare came into be. So insurance was available, and some kind of a government-funded retirement for those who did not have retirement from their employers. Retirement started happening, and we began to see this trend towards 65 becoming a retirement age, and even younger people starting to retire, despite the fact that was not, Medicare didn't take effect and Social Security didn't, with a few exceptions, take effect at that age. There still was a younger age for retirement. And then, beginning in the late 90s, the labor force started an uptick for older people. You know why that is? Yeah, so some of it has to do with the demographics I've shown you. You're healthier, you're younger, and frankly, you feel good and you don't want to retire. That's one reason. But then there were also financial reasons that kind of drove those decisions for the labor force. And this only goes to 2006, but it has continued this trajectory up in the 65 to 70 age group. Labor force participation of women, much flatter. And one of the reasons it's flatter is because you didn't start out with this large labor force participation over here, because the women entering the workforce in large numbers tended to occur in the late 50s into the 60s. So the reason it kind of appears flatter, in reality what's happening is that there's an increase in labor force participation among women across all age groups. But it just looks different because there wasn't that high level of participation up until the late 60s. A little bit about a survey that was taken of individuals starting at 65 and going up into 85 and above as to their perception of their health status. What you can see here is that more people reported themselves as being in good to excellent health than maybe me as the physician would have reported them being in good to excellent health. We have a sense that we're doing okay generally, and that's a good thing. I think optimism and a sense of recognizing the ways in which your health is good increases your ability to age in a healthy fashion. This is just a demonstration of Medicare enrollees and the percentage of their income or their healthcare expenditures that goes for different things. And this really does not necessarily have relevance as it pertains to aging in place, but I thought it was an interesting slide. And when this happened, the difference between 1992 and 2004, you'll notice that the biggest chunk of that difference was prescription drugs. And what happened in response to this slide around 2004 was Medicare Part D. Medicare realized, or we realized as a society, that prescription drug costs were spiraling out of control, and we had to do something. If we were going to utilize the innovations that were occurring in the pharmaceutical industry in caring for chronic health and chronic disease, we needed to do something to make that more affordable. And finally, I think this is the last of the kind of the demographic slides that I'm going to show, because this is important as it pertains to aging in place. And that is, even though most people report being in good health, the majority of people or close to the majority of people have hypertension, have arthritis, a good chunk have some form of heart disease, and then other chronic conditions are prevalent in this population. Despite that, we feel good about it.
Right? That was the United States.
Pardon?
United States.
This is the U.S.
How does that compare to other, like,
Well,
European?
so every one of the, so that's a great question. How does this compare to the rest of the world? And there are lifestyle effects, lifestyle indicators that have an effect. I told you I would do that. That have an effect on some of these areas and others not so much. Diabetes, for instance, and this is a tiny number compared to 2016. But diabetes, for instance, we have a much higher rate of diabetes in our children, adolescents, and older folks, and it's purely lifestyle, frankly. So hypertension, heart disease, stroke, and chronic emphysema, and to a lesser degree asthma, are in many ways lifestyle. Their diet, smoking, exercise, and the rest of the world is catching up with us on these. We have historically had higher rates of these than the rest of the world, but they're catching up. They're learning how we've screwed up our health really, really well, and are following suit pretty well as well. Okay, so what does all this mean? Why did I spend 15 or 20 minutes talking about all of this before I even got into the meat of this? I think what this means to me is that as we talk about either staying at home or moving to assisted living or needing help in the home, we have to realize that there are chronic illnesses that will occur, and those chronic illnesses are typically related to, the chronic illnesses that we get are typically related to lifestyle and wear and tear. They're related to the effect that aging has on the body, number one, and the things that we've done to ourselves to get us to that point. I don't have the slide to show this, but the mortality rate. So we've spent a lot of money on heart disease. We've spent a lot of money on cancer, and we've made impact here and there on cancer. But we spent a lot of money on heart disease, and we have made incredible inroads into the prevention of or the if you will, kicking the heart disease can down the road. It is unusual. When I was in training, people who came in with heart attacks were 50-year-olds. They were all 50-year-olds because if you had heart disease, you didn't live to be 60 or 70. And nowadays, the people who come in with heart attacks are 70 and 80. And it's because we understand now that hypertension, that hyperlipidemia, that diabetes, and that smoking are contributors to that disease. And we have made impacts in preventing particularly that disease. And what that's done is it has helped us understand what the true diseases of aging are. And the elephant in the room, the truest disease of aging is Alzheimer's disease, and what it's resulted in, the fact that we have kept people alive longer, we have made huge impacts in stroke and heart disease, is that we've been left with 5.3 million people with Alzheimer's disease. And left figuring out how do we take care, how do we do for Alzheimer's disease what we did for heart disease, and that's the big question. So wear and tear, cell death, despite. So you could go home and Google tonight, just to do it. Google prevention of aging or anti-aging, and you'll find all kinds of stuff. Honest to God, you be careful if you do it, because you might fall prey to some of what they tell you, and you might end up spending thousands of dollars at the health food store if you're not careful. But Google anti-aging, and you'll find that there are people who are convinced that they can prevent cell death. And I will suggest to you that there are things that we can do that delay cell death, but we can't prevent cell death. for any of you who are anti-aging gurus and feel like you're on the path towards human immortality, I think that's probably not going to be the case. I'll be happy to eat my words if that is the case. But so what it all got down. My last slide, the last line of that last slide was a loss of reserve. We are endowed with an incredible amount of reserve. Every one of our body systems has so much reserve. I mean, we have so much reserve in our renal system that if my brother needed a kidney tomorrow, I could give him one of my kidneys and my renal function would be just fine. We have there's the ability for us to tap into all that our brain holds is incredible. That we can't even begin to understand the ways in which we could tap into that. And it's all about reserve. But what happens with aging is that we lose some of that reserve. What can we do to try and slow that down, or to at least to overcome that effect? I would suggest to you that there's good data to say that physical exercise, that healthy eating, that lifelong learning in some fashion. I don't necessarily mean, although I guess Virginia Tech would love this, staying enrolled in college for the rest of your life and paying tuition for the rest of your life. That maybe so. Preventive strategies and avoiding exposures to toxins. And I left this one on here knowing that there'd be hands raised. Okay, what are the toxins? What do we need to avoid exposure to? And frankly, I don't know. And it gets my mind spinning whenever I start reading about this, and whether coffee is good for me or bad for me, whether chocolate's good for me or bad for me, whether this is good or bad. And every week it seems like what you thought was true the week before is now not true. So I'm not sure. We know what some toxins are, frankly, but we're not really sure. I don't think anyone would argue that smoking is toxic, right? And so we pretty well know that. But other things, is one glass of wine a day good or bad? Depends on what you read. Is dark chocolate good or bad? It depends on what you read. And it goes on and on. I'm of the opinion that coffee, one glass of wine, and dark chocolate are great for you. And I'm living by that, and so I'm just kidding. But I've not seen anything that's convinced me otherwise, so therefore I will continue with my coffee, my dark chocolate, and my glass of wine. So why are we living longer? I think, so this is a slide I alluded to earlier, and we've talked a little bit about it. So there are clear improvements in public hygiene, food, nutrition. You could argue that depending on the food and nutrition that you're getting, but improvements in public hygiene, reductions in infectious disease deaths due to immunizations and due to antibiotics. I think if you needed me to prove that to you, I could very easily do that. Improvements in prevention and care of heart disease. I've already talked about that a little bit. And specific life-prolonging innovations that we've had, dialysis, organ transplantation, implantable devices. All those things contribute to our increased longevity. And then improvements in cancer care. While we're not close to curing cancer, if you will, there are improvements and remarkable improvements in the last 20 years in cancer care and in cancer survival. So I'm going to spend the rest of the time talking about what are the risks that we face, given that we're gonna live longer, right? What are the risks that we face, and how can we overcome some of those risks? So falls is one of the leading causes of death in the elderly population. The mortality rate, what mortality rate basically means, the rate of death at a given period of time. So the 1-year mortality rate after a hip fracture is equal to or exceeding the 1-year mortality rate of almost every cancer. Pancreatic cancer is above it, but just about every other cancer has a higher 1-year mortality rate than a hip fracture does. I mean, you think hip fracture, everybody breaks their hip, right? The chance of death in 1 year after a hip fracture is in the teen. In the 20s and to 30%, depending on who you read and what population you're looking at.
And is that due to heart?
Is it what?
Why
So the reason is, so there's a lot of reasons. One is you tend to be older by the time a fall causes you to break a hip. Osteoporosis, despite our efforts at preventing it, does progress on the older we get, and so a fall in a 60-year-old is not as likely to result in a hip fracture as a fall in an 85-year-old. So they start out older. So that's kind of the asterisk to that statistic. Cancer doesn't. It does, but it doesn't typically start out at an 85-year-old. So they're sicker, they're older, so they're more likely to have other things. It's not they don't die of the hip fracture. They die of the heart disease, the pulmonary embolus, the ravages of immobility that might result from the hip fracture in the first place. Motor vehicles, the trauma service at Roanoke Memorial for the last 10 years has, they've kept statistics from the time they were at Level 1 Trauma Center, but for the last 10 years, the age of their motor vehicle crash survivors that come onto the service is increasing fairly rapidly. And the mortality rate, again, for the same reason, because the older we are, the more likely we are to not survive any kind of insult. The good and bad of sunlight, the damage that it can occur, but also the need for vitamin D and the sunlight's conversion of vitamin D to its active ingredient. And then depression or isolation that is, I consider to be a huge risk in this population. We've talked about falls. I'm going to quickly go through some of these slides because I want to get to a few important points. But I think I've made the point about falls. Hip fracture, 300,000 per year, $6.8 billion per year, 15 to 20, and actually some studies have that up as high as 30% one-year mortality. Hearing loss and the effect. You think this is minor. This is just sensory deprivation. It's not just minor. Hearing loss does affect one's ability to function effectively at home. My dad is all but deaf, and thank God for my mom, who is there to answer the phone and to take care of things that require hearing. He refuses to do anything about it. But so if she were to go before him, I'm not sure, because of his hearing loss, I don't think he could stay at home alone because of this one, what we would consider to be a minor problem. So aging in place, I believe, requires a holistic approach. An approach that kind of crosses a lot of boundaries, a lot of disease boundaries, a lot of service boundaries, and the requirement for a lot of different people to be in there. It requires that we are healthy. We individually are healthy. We're exercising. We're doing exercises of our brain. And I'm not here to endorse a particular product that exercises our brain, but a patient does not leave my office without me saying to them, you need to be doing something that requires you to be thinking, and watching Fox News is not one of those things. Social engagement, healthy diet should be healthy diet, and to recognize your limitations. One of the biggest risks that we all face is not knowing our limitations and not knowing when to seek help for whatever that limitation is. As a physician, I need to know what I know and know what I don't know. I need to know when I need to call the cardiologist or the surgeon. I can't do it all. And as a human being, I need to know what my limitations are as well. Advanced care planning, I know you've had a talk on this, so I'm not going to go into this, except to say, please do it. I see people when I'm on call for palliative care whose loved one has, for whatever happened that resulted in a major catastrophe, no longer able to make decisions for themselves, had no advance directive. The children have no idea what their wishes were, and it is heart-wrenching. Depression, don't forget about the likelihood for depression. The age group and the demographic with the highest suicide rate in the U.S., and this has been the case for 30 years, the demographic with the highest suicide rate are older white men. It's because of loneliness, and it's because of access to the ability to do that, but it's depression, loneliness, and access that makes that demographic at high risk for suicide. Depression can prevent very atypically. I teach my fellows all the time, if depression is even a fleeting thought in your mind as you're seeing a patient, you better convince yourself it's not depression. And there's a couple reasons for that. One is because it is so devastating, but more importantly, it's treatable. And we can fairly safely treat that condition, whereas with some of the other things we're faced with in older people, it's less successfully treated. Yes?
I was wondering about the more information about the suicide rates, because I do a lot of work with First Peoples and Native Americans, and that research was showing that actually the teenage population of boys there was the highest in the United States of suicide rates. And so I'm not contradicting you, but I'm trying to understand how the demographics.
So it's a difference in successful in successfully committing suicide and attempting suicide. Older adult men don't have the highest rate of attempting suicide. They have the highest rate of successful suicide. So it depends on the statistic you're looking at. If you're looking at suicide attempts, successful or not, then yeah, teenagers and certain demographics of teenagers are the highest rate. Cognitive health, dementia is not inevitable, but cognitive change is. All of us, I have to do it, is as we age to develop reminder systems. Just because you need a list and you didn't need it 10 years ago doesn't mean you're getting Alzheimer's disease, thank God, because I need a list and I didn't need it 10 years ago. But we do need to recognize when those changes are occurring, and accept the assistance that might be necessary. The tendency for someone who is developing some cognitive change, whether it's just physiologic cognitive change or dementia, is to disengage and to be embarrassed about it and to not socialize, and that's probably the worst thing you can do. Remaining engaged is extremely important for this population, and I'm going to talk in a minute about utilizing community resources, because that I think is the linchpin to it all. Polypharmacy, remember drugs, and just because something's over the counter does not mean it's safe. That's a quote that so easily comes off my tongue that it's because I say it 10 times a day. Tylenol PM is my least favorite medication there is, because you go to everyone thinks Tylenol's safe, and so Tylenol PM, that must be safe too, right? And so it's just used all the time and to the detriment of people. And another slide another picture from Dr. Seuss's book about polypharmacy and all the medications that are out there and may be necessary. Fall prevention, Tai Chi or some kind of exercise, both for flexibility and for strength. Vitamin D, if you're not getting sunlight or if your vitamin D level is low, and if you haven't, if you or your loved one have not had your vitamin D checked, I suggest that you do that. And see whether vitamin D supplementation is going to be necessary. Home assessment for fall risks. I don't make as many house calls as I used to, but when I made a lot of house calls, and when I make a house call now, the first thing I do, people when they let me in the house, they think I'm being rude because I don't look at them and talk to them right away. I'm looking around the house and kind of scoping out where are the problems. And those problems are primarily two, but multiple, but throw rugs and electrical cords. And I will look for throw rugs and electrical cords, and I will ask people to, so a lot of people love, they have their wood floors and they want to protect their wood floors, so they put throw rugs in it. I will try to convince them not to do that, but if they insist, if they'll put some kind of a non-slip thing underneath it, would be helpful. The get up and go test is just something we do to try and assess one's ability to function and assess one's fall risk. Sleep disturbances, for a variety of reasons, our sleep as we age is less effective, and we need to recognize the importance of sleep hygiene. I think that the newer television sets are probably one of the newer LED kind, the blue background TV sets, cause a lot of visual stimulation and stimulation that takes a while for us to kind of remove from our consciousness when we're trying to sleep. So I recommend, for sleep hygiene purposes, I recommend no TV for 30 minutes prior to bedtime, reading or something that's more soothing as opposed to stimulating. Trying to stay more active during the day, preventing daylight napping. Bright light therapy, especially during the winter months, can be helpful. Treating associated problems. Medications are purposefully low on this list because I try to avoid sleep aids as opposed to sleep hygiene improvement. But sleep, despite that, is very important. I've talked a little bit about driving. Driving is a major indicator of independence in the U.S. For 3 years, I practiced in Washington, D.C., and I tell this. This is a sort of a true story. When I would tell people up there they couldn't drive anymore, they'd say, "Thank God I don't have to get out on the road anymore." But when I tell people in Roanoke that they can't drive anymore, they're what do I do? And I get that. What do you do in a place that really does not have great services available to those who can't drive? Some of the we talked a little bit about hazards, but also poor lighting, stairs, and narrow hallways in addition to throw rugs and electrical cords. And there are things that we ought to be looking for in our parents' homes and in our homes to try and prevent this. Remember, falls and hip fractures are huge, and just having the light. If you don't have the ability to kind of plug a light in without putting a cord across the room, then either some home modifications or changing where you have the light needs to be done. I really can't emphasize that enough. I've seen a lot of people who have had a fall because of tripping over a cord. People were asked the kinds of changes they would make to their home if they were going to make changes. And you probably can't read this. I'm sure you can't because I can barely read it. But things like bathroom modifications, hallway modifications, doorway modifications, and then furniture changes are the kinds of things to look at. And I am not an aging in place contractor. I don't have particular aging in place contractor, but in every community, or at least in the New River Valley and the Roanoke Valley, there are contractors who can go into a home and help you make those modifications that are necessary, from grab bars to higher toilets to curbless showers and wider doorways, ramps, etc. All those things can be done to make the home safer for the aging individual. So the care of our older Americans is going to require an increasing proportion of healthcare services. And by services, I don't mean doctors. I mean support services that are actually providing and assisting with the care. It also will require clinicians that are attentive to the needs of the geriatric population. And there will never be enough geriatricians in the country. We're not training enough of them. There aren't enough that had a grandparent or that loved the stories. But what we try to do is this kind of thing, and that is educate not only the public but the physician population as to what are the keys to helping our aging population age in a healthy way. So in conclusion, every patient is different. I've got this week. On Monday, I saw 4 patients, but 3 of them were from a so it was in my memory clinic, so they all have memory issues. But 3 of them had very early dementia, and their testing would put them in almost the same spot in as far as dementia goes. But there are 3 very different stories, despite the fact that they're, from a cognitive standpoint, pretty much in the same place. One has no personal assets and was living with her functionally alcoholic brother and had no support. He couldn't help her with medications or wouldn't help her with medications and really was able to be semi-independent, but didn't have the support to be semi-independent. Her one child lived in Florida. So we have this situation where my recommendation was that she needed adult daycare or PACE or something where there was someone and a pretty intensive degree of support for them. The second patient was someone, again, tested almost identical, about the same age, whose daughter she lived by herself in her house, but her daughter lived in Roanoke and was close by and able to kind of check in on and fill the pill box and take care of finances and do the things that the first patient's brother would not do. So this lady all she really needed was someone to come into her home once a day to make sure she took her medicines, because the pill box was there, she just still forgot to take it. So she needed someone to be her reminder for her medications. Otherwise, she was perfectly fine living where she was. And then the third patient, who he and his wife had decided, again, story was almost identical from a cognitive standpoint, but he and his wife had decided 8 years ago to move into a continuing care community and were living in an independent apartment in a place where there was a safety net. And I felt very comfortable knowing they were independent, they were driving and doing everything they wanted to do, but there was a safety net where they were. So you have the same clinical story with three very different social circumstances around that story that resulted in three different care plans to be developed. George Burns says you can't help getting older, but you don't have to get old. And I really like that. It's a mindset, right? We are getting older. It's going to happen. But however we define old, and whether it's age or debility, we don't have to get old. Or like this lady. We have resources, and many of them are here today, from family to in-home caregivers, adult daycare, PACE, hospice, and home care. We need to take advantage of them, but more importantly, hear me here, we need to lobby our elected officials that what we have is awesome, but it's not enough. And we're facing a huge, huge issue. 20 years ago, a book was written called based on an African proverb. The book was called "It Takes a Village," and the proverb was, "It takes a village to raise a child." And I will be honest with you, I cringed at that proverb, because at the time I was the father of young children who were in school, and I was a family doctor, so I was taking care of young families, and I really kind of recognized that parents were allowing some of their parental roles to be done by other people, and I felt like this might be a message that even further eroded the parental role. Fast forward 20 years ago, and whether or not you ascribe to that proverb, the reality is it does take a village to care for our aging population, and we need to embrace that concept and support those members of the village who can do that. Thank you very much. I've taken almost all my time. I don't know, a couple questions? Yes.
You commented at the beginning of your presentation that the ideal is for everybody to age in place in their home, but that admittedly there are circumstances where that may not be the wisest choice. And you went through quite a few things, but could you just, what are your top 3 or 4 indicators that you look for to say that, well, gee, maybe we really ought to be looking at an alternative location?
Yeah, so I think the most important indicator is not an indicator of the person or the patient themselves. It's an indicator of the support that exists. So, for instance, in the case of the 3 cases I gave you, the first case was really the social support is pretty much absent. At least the family social support is pretty much absent. And the ideal for that patient, and I told the caregiver and the patient this, the ideal for her would be assisted living. I think it would absolutely have been get her out of the home where she was stressed about her brother and her brother offered her no support. The ideal was assisted living, but the financial reality was that was not going to be possible, at least not yet. So to me, and adult daycare and PACE is not a compromise, but the other alternative in that case was at least having a daytime safety net and daytime care so that she's not left alone, and so that we can make sure she's getting her medications and the like. So the biggest indicator is what support systems are available that can maintain that home situation. I've got one of my dearest friends. Her father has. I've never seen her father, I just hear her stories, has what I would consider, based on the story she's telling me, fairly moderate Alzheimer's and is living alone, and I cringe every time she asks me a question and tells me a story, because I'm thinking, oh my gosh, this is a disaster waiting to happen. I mean, they've not unplugged his stove. While he doesn't have the wherewithal to drive, his car is still in the garage, and all those things are still present. You know, one of my, in addition to one of the other things that are so easily off my tongue is, you know, we want to maintain, I want my patients to maintain their independence within a safe parameter. So safety, whatever that safety looks like, and if you can somehow package safety, then staying independent is the goal that we ought to shoot for. But, you know, assisted living, independent living, senior apartment, and even nursing home sometimes is necessary. Thank you very much.